Hello, friends. So, good evening. So, today I'll be talking on this important aspect, home care. So, this is a little outside the domain of intensive care, but we wish to see whether intensive care has a role in this home care because there's a lot of noise in this home care segment across India, and we see there is a good space where possibly intensivists should have a role to play and whether there is any science behind intensivist role in this home care and whether that makes a difference to the outcome of the patients is what we would possibly deliberate. So when we look at the landscape of healthcare in India, so it would possibly be limited as the days progresses like West, it would be more limited to outpatient care, acute care, because that we cannot shy away from. So which means intensive care and OT and post-surgical care and all the procedures, cath lab and endoscopies, all that comes under acute care and long-term care. So this is where I think we are still lacking sort of an organized sectors in this long-term care. So when we talk about, so gone would be the days where people would get admitted to get just an antibiotic or just to get certain investigations done or just get admitted for blood pressure control or blood sugar control, like typically how we would have seen during our evolution as a doctors. I think that care would slowly dwindle. So we would see more of patients coming for a outpatient consult. Acute care, obviously, they have to be in hospital, and long-term care is where we would be heading. So when we talk about long-term care, so there are different domains in this. So one would be where their acute condition is fixed and they would go to a place where convalescence has to happen, where they would get possibly good physiotherapy, good nursing care, and good sort of a rehabilitative care. And there is another aspect in long-term care, which is palliative. So palliative is like where there is no reversible condition and where the whole focus of management would be to relieve the pain and suffering. So that is also a space where long-term care comes. And the third most important where intensivists would have an important role is end of life care, where obviously the patients would have a non-reversible conditions and they would progress to death, and to making that whole process pain-free with the family present is called end of life care, and we have position statements on this. So this is where the whole space of long-term care comes. And as you clearly see, my intensivist friend would agree that our role will be very much be there in palliative and end of life care. So that is where our role, and even palliative care physicians would be involved in that. So this is where our whole role comes. Even in convalescence or rehabilitation, where someone is on tracheostomy, our role becomes imperative and important. So that's why it is important we are associated with this concept of healthcare, because we would be looking at as an extension of our care that we would be providing. So when we talk about this long-term care, so if you look at our country right now, we are looking at this care predominantly being provided in hospital. I'm sure most intensivists who are listening to this would know that patients undergo palliative care within the hospital, and end of life care, forget hospital, it typically many places it tends to happen in ICU. So this is something which we should possibly, this concept will move away from the hospital. So we should be looking at this care being provided in a standalone center, which is long-term care, or most important at home. I think this is where we should be really looking at evolution of health in India, because the cost would be cut and there are a lot of advantages which we would look at. So hospital is not the place that we should really look at someone undergoing palliative end of life care, because this is not an ideal environment. So we should really look at a standalone places where the whole focus is on symptom resolution or pain relief or symptom alleviation, I would say. And hospitals are not the place where we should really look at. And the home care, so early discharge to home is something that could be facilitated. When we say home care, they go to home not to be just, with a clearly defined care processes at home that takes them to wellness, recovery to wellness. So, and that would possibly facilitate early discharge to home. And this would possibly lead to evolution or emergence of telemonitoring, which is really taking off in a big way. And thanks to COVID, tele-ICU or telehealth or digital health is here to stay, to provide this extension of care and monitor the patients once they go back from ICU or acute care center, to make sure that the progression of events would take them to favorable recovery. And end of life care is also something that could possibly, that could and that should possibly be provided at home. So when we look at the background, so the worldwide or in India for specific, there are around 2.5 ICU beds for 1 lakh patients. So which means it's a very less number of ICU beds that are there for 100,000 patients. So if you take 1 lakh patients, currently we have around 2.5 ICU beds, which is very less. And sending and clogging this bed space for patients would obviously increase the cost. So sending them home early would obviously curtail the cost for them, and it becomes a lot more cost effective in managing with quick sort of a discharge to home. And it obviously creates better space that would be available for much needy patients. So ICU beds is something which is very valuable, so no one should be denied the space. And this works more in public places also in Western world, where ICU bed is hugely valuable, and they're on demand. So it is important that once patients don't need ICU, there's no need for them to remain in ICU. They need to be moved to a place for ongoing recovery and create space for others. So when we looked at home-based critical care, so why there is a need for home-based care? So the reason is patients are becoming elderly. The type of patients we are seeing currently, as opposed to maybe 20 years back or 15 years back when we were doing medical, is that we are seeing a lot more patients with a lot more comorbid problems, and they are living much longer, and the vulnerability is much higher in these patients. So they need to have certain processes put in place to be looked after. And there are no family members who currently would be at home in most of the nuclear families to take care of these patients, because the both couples would be working most of the time, and it's a nuclear based family, so gone are the joint family system. So there wouldn't be any personnel who would be looking after or who can care for these elderly vulnerable patients, and timely drugs may not be something that would not be given, or there would be a lot of other dimensions, and even nutritional sort of optimization would suffer, and physiotherapy services would be suffering because of the working couple. And it's a nuclear family sort of a situation where it is impossible to provide care for this. And that has led to emergence of this space, which is well established in the Western world. We have these hospice or long-term care centers where these vulnerable patients will be looked after until they can look after themselves after going home. Because if they're not in a position, they can look after themselves, or they can take care of their activities of daily living, then they would be very vulnerable for events that would not facilitate a good improvement or progression. So when we look at this data from UK in 2015, so these are the discharged patients from acute care who have been discharged. As you see, there's a very small percentage, around 5% of the patients who do not need any support. And around 10 to 15%, maybe they would possibly need little support, but no additional support. But if you see significant proportion, up to 40% of them, 25 to 40% need support from intensive care when they go home. So which means to say either they in UK they are sent to additional community support or transferred to community bed facility, which means this would not be very different in India also. So when they go home, they need to be taken care with some sort of a healthcare processes put in place. Otherwise, recovery would not be optimal. And it is shown that 50% of the patients many a times were treated in ICU could possibly be sent to some sort of these centers where they can be looked after, where they would need around intensive health intervention. 80% of them can be discharged early. So that is what they have shown. And this is the group of patients who would benefit for some processes put in place for the effective recovery to happen. So when we talk about home care, the studies have shown that from ICU, when there is an elderly vulnerable patients where there is complete recovery to wellness that has not happened, they need to have some care given at home for good recovery to happen. And this is what was shown. Up to 40% of them would need some help. So, and it is shown that unnecessarily remaining in the hospital when they don't need increases the risk of hospital-acquired infections by 13%. And the device-related infections also occur up to 27% when they unnecessarily continue to remain in sort of a hospital-based setting. The advantages of sending to home, see, they have shown that once they get discharged from ICU, 5.6% of them tend to get readmitted to ICU within 30 days of discharge. So that is something which we also see here. Especially this happens in someone with comorbids or elderly or vulnerable patients. And so this is an interesting sort of a finding where they showed the mortality at home was significantly less as compared to someone who has remained in the hospital for ongoing treatment. So which means sending them earlier to transition care has shown to lessen their mortality because the home surroundings and possibly psychological well-being also is better, and the possibility of them getting better is much higher. So this was shown. And even they have shown surprisingly falls at home was lesser as compared to falls in the hospital. I'm sure we all could possibly allude to that, that falls do happen in hospital. And the cost was 19% lower when they were sent home earlier, because you would save a lot of money on unnecessary diagnostic tests or unnecessary treatment and all the clinical consultations that gets put for these patients. So it is important that in Indian circumstances, I think this would become very pertinent that we reduce their cost by sending them home earlier, not keeping them in hospital-based setting for a longer time. So when you look at end of life care in Indian context, so 83% of the patients who come to ICU or who have non-reversible conditions and who are on a palliative mode, their questionnaires have shown that they would rather prefer to die at home than in hospital. And many a times, I'm sure most of the listeners would agree, many a times we get a request from many families that they would prefer to die at home, and that is called as good death. There is a position statement from the Indian Association of Palliative Care, which talks about what defines as good death. And 78% of the patients with advanced illness in our Indian setting, typically, this was shown in this article which came in Indian Journal of Palliative Care, they get discharged against medical advice where there is no hope of them making recovery. And we see this very often when we say there is no hope of them getting better. So they would not opt for palliative care or comfort care. Rather, they would say, we will go home. And what happens at home is more important. When they get discharged against medical advice, once they go home, so there is no sort of a measures to relieve their symptoms or the pain or suffering or agony, and they eventually have miserable death. So this is something where there's not much of focus put in, where these patients need to be looked after, cared for, make sure that they don't die with a lot of pain and suffering. So this is not happening in most places in India, and this is where the concept of home care comes. And when we talk about palliative care, so there are certain situations where you need symptom control, supportive care, and disease management. So when there is a disease management, obviously you need a hospital-based setting or an institution-based setting. But when we talk about only symptom control and supportive, this can be provided at home. Or if it is only symptom control or end-of-life care, these two can be provided at home with all the processes put in place. So this is what we are looking at. So this is the space where there is a huge space where processes can be put in place to alleviate pain and suffering for our patients without incurring too much cost. So this is where we are at this point of time. And when you look at end of life care in Indian context, in fact, Indian government has come out with a position statement on end of life care. And in fact, the government of India in the position statement does suggest that every hospital should have end of life care policy in place, and there should be a comprehensive care in and palliative and end of life care processes is something that is recommended to be there in every hospital. So how much it's happening, it's anybody's guess, but Government of India has come out with a sort of a draft that these services should be provided in every hospital. And to that extent, Indian Association of Palliative Care has come out with a statement saying that palliative and end of life care should also be a part of community and home-based programs. And when they suggest this, they also suggested good standards have to be put in place or guidelines, and a good guideline has come out with from Indian Association of Palliative Care. And these guidelines or standards should be monitored by national and international accreditation. So to that effect, even there is a government's intent or initiatives to put processes in place so that the pain and suffering is sort of alleviated or taken care of by putting all the standard guidelines in place. And it also suggests that every doctor should be trained in end of life care or palliative care so that the symptom relief and palliative care or alleviation of pain could be addressed. So when we look at the literature review of end of life care, so this is the studies from Tunisia, Busara et al. In 2006, where they showed 10% of the ICU deaths happened at home. And this was consistent with the wishes expressed by the family. Tunisia is an Islamic country, so 10% of the ICU patients preferred to die at home. And this was a study which recorded that. And in fact, family were very happy and they were grateful that that this process was put in place where patients could die at home with all their family members present. And this was a Chinese study where they showed 26 to 44% of the patients when they surveyed in 2003 to 7, they preferred to die at home, and they did facilitate death at home, following and adopting these Chinese cultural beliefs. So, which means to say countries are moving to at home with all their family members present. And this was another study by UK where they showed even withdrawal at home is something that they would facilitate in UK as per the family wishes. So, which means to say more and more families are reconciling, and even in the past, you would know most deaths would happen at home with all the family members present historically. And this has changed somewhere in between. Now, families are reconciling to the fact that a good death means that death happens at home, obviously without pain, with all the family members present. So this is something which is a paradigm shift into what many doctors would believe, that death should always happen in hospital. So this is something which is transforming our healthcare as well. So, and there is a position statement from our intensive care society and palliative care which defines what good death is. So good death is typically which happens at home with all the family members, and obviously not in pain and sufferings. And they have defined what like how important is quality of life. Even quality of death is something that is emphasized in this position statement, and they come out with guidelines what it means to be good death. So this is where the whole focus is. So now we'll shift gears as to the components of e-monitoring. So when we send someone home and we say the pain has to be alleviated, they should not suffer, it means there should be some continuum of care. And this continuum of care can happen only with digital health. And when we talk about digital health, there are a lot of these parameters that could be monitored remotely. And there are now technologies advanced to a point where remotely patient would be connected to some sort of a leads, and all the vital parameters could be captured and they could be monitored remotely, which is tele-ICU or telehealth or digital health. And all these parameters have been shown to be effectively monitored in a remote way. So this was one study from Australia where they showed, Australia is a big country, so you cannot have a specialist sitting in every hospital. So this was one sort of a pilot study where they looked at telemedicine and its role in administering antibiotics. So here they looked at 83 patients where 2,261 outpatient administration of antibiotic therapy was done. And here they covered a median distance of 288 kilometers, and favorable outcomes was achieved with 87% without doctor physically present. It means to say with digital health, there's a lot of things that one could accomplish without doctor being present. And here they showed a good favorable outcomes in sort of monitoring outpatient antibiotic therapy. And so these are other studies related to ICU. So this was a Breslov et al. Study in ICU where they showed significant reduction of mortality by 33% with telehealth, and duration of mechanical ventilation was reduced to 25%, and length of stay was reduced to 17%. And in chronic heart failures, this was a study where they did a weekly monitoring of all the parameters by telehealth or digital health. And they showed 28 patients here got telecare and 29 got usual care. And they found the hospital readmission was significantly less in a group which got telecare. So what the reason we are addressing this is, so you can see the evolution of healthcare. We are talking about home care. We are talking about an institutional care or transition care. But these two domains of care are connected to a hub center which would be monitoring them. So it is an extension of, say, ICU or any other inpatient services where these patients are monitored in some way. So if you see this study, which is a very interesting, heart failure patients, once we send them home and they take this additional help of having a telemonitoring, which means you can identify certain events or that would possibly cause an adverse event within the patient, which can lead to an adverse outcome. So by monitoring them, they found that hospital readmission could be reduced, and even mortality, there was a signal towards a reduced mortality by using this telecare. And this was another study by Kistner et al., where they had patients with atrial fibrillations post CABG. And if you see 119 patients who are on telecare, which means there was a monitoring of certain parameters as compared to 238 patients who are not tele, the atrial fibrillation episodes was significantly less, 14% as compared to 26%. And this was another study by Margaret et al. So twice a week, they monitored the patient's telecare. And even here, they showed the hospital admissions were significantly reduced. It was 38 per 100 patient years as compared to 77 in 100 patient years in usual care. And that was statistically significant. And even the length of stay also was significantly reduced with telecare as compared to the usual care. So what this basically emphasizes is sending them home is okay, having a home nurse is okay, having all the physiotherapy services, but connected in some way to the main treating physician through a digital health or telehealth can significantly improve their outcome and quality of life is what these studies have shown. So which means to say the home care, what we're talking, having some sort of a tele-monitoring will have an added advantage of improving the outcomes is what we can make out from these studies. And these are the other two studies which showed patients who were monitored with telehealth had a better blood pressure control. So the blood pressure and compliance with medications and even the blood sugar control could be more effectively managed. And so this is as I said, most studies show that mortality reduces by 33%, duration of ventilation was reduced by 25, length of stay and readmission. So to conclude, so as you see, it was just a brief sort of an overview as where intensivist has a role to play in this sort of a landscape of palliative care, end of life care, and home care by adopting the digital health or tele-ICU or tele-monitoring. So where we should possibly be the part of this continuum of care that happens from hospital, from ICU to whichever transition care they go to. And that is where I'm seeing the role of intensivists and a bigger footprint that possibly the intensivists would have. So the future of healthcare, as I see right now, when you look at this picture as an intensivist confined to a ICU within hospital, I think we should open up our horizons. And when we look at even financial sort of a thing, intensivist looks at maybe 10-bedded ICU within hospital, and the type of monetization that he would derive is only less than 5%. I'm sure, because I've done my MBA, so I know the type of monetization that happens is less than 5% or from the sort of a expenditure that happens. So he should possibly look at extending his domain into into continuum of care with the long-term care center or the home care in monitoring these patients and influencing good outcomes is the way I would look at it for our intensivist group. So that is the reason I thought it is good that we talk through the science as to where we see the healthcare heading and how intensivist role may not in future be only confined to four walls of an ICU. It may be beyond that, where we continue to monitor the patient with all the technological interfaces that are present and influence good outcomes. And as I speak now, there are intensivists who are doing active home care digital health monitoring. And there are big groups of intensivists across India who have started off this process. So it's about time all the junior lots also adopt this and be a part of this journey. So thank you very much. So I end with this nice quote from our Shishi. So thank you one and all.